December's Medical Monday, and we're gonna punt because we can't make the Stevie work. So they're gonna do the best. And we want to welcome Dr. Meyers. He's part of the Reid Health Emergency Management Team.
Yeah, the Emergency Medicine. I'm also the Director of the Urgent Care.
Okay.
Thank you so much. So thank you so much for letting me join you today. As she said, I'm Dr. Meyers. I'm one of the emergency physicians at Reid Health. I also work in the urgent care as one of the urgent care medical directors. So certainly acute visits are my thing, right? And especially this time of year, we're seeing a lot of acute visits by way of that snotty nose, that cough, the nasal congestion, my throat hurts. Probably everyone in this room has had some of these symptoms over the past few weeks. So I'm going to talk a little bit about viral illnesses. We're going to focus on a few viruses specifically, some of the ones that I think people are most interested about: influenza, COVID, and RSV. I do like the babies, so we'll talk about the babies here in just a second. But let me tell you a little bit about myself. I did my undergraduate training at Butler University, majoring in biology and chemistry. Went to medical school at IU. I did my residency training at IU, so I worked primarily at Methodist, Eskenazi hospitals, as well as Riley, downtown Indianapolis. So worked at 3 level 1 trauma centers for my training. And then my wife and I located here back in 2020. 2020 was kind of a crazy year. I don't know if you remember what happened in 2020 for an ER doc, but we moved here in 2020. We've got, and I had all these cute pictures of my kids on the slideshow here, but we have Jack, who is 3. He'll turn 4 in January, and we have Owen, who will be turning 2 in March, and then we're actually expecting baby Meyers number 3 in January, so we're really excited about that. My wife is a school counselor over at Seton. She is a school counselor and works as a math teacher there. So both of us have been professionally involved in Richmond. We are so happy to live in Richmond and to work in this community. So I know maybe some of you have seen me in the emergency department. I always tell patients that it's sort of like, you know, a confessional at church, right? I will never remember you again, right? What you told me when you leave the emergency department. But so some familiar faces, and again, I appreciate you having me here. So it's a bustling day in the emergency department. We've got a patient who's delivering a baby out in the parking lot. We've got a 3-year-old who's choking on an M&M. And then we have a 70-year-old lady who comes into the emergency department, and she tells me, "Doc, I've had this runny nose and cough for 4 days. You have to do something." All right, ma'am, let's talk about it. Okay, so today's topic is going to be about respiratory viral illnesses. As sort of an outline for this talk, we're going to talk about what the upper respiratory infection entails. Again, from experience, you probably all know what this entails, but we'll talk a little bit about that. We're going to talk about influenza. We'll do a little deep dive into the flu. We'll do a little update on COVID-19. I know we are all COVID fatigued, but let me tell you, COVID is still around. So we'll talk a little bit about COVID. We'll talk about the babies. I love the babies. I actually work in the emergency department as our pediatric care coordinator. So my specific area of interest within emergency medicine is pediatrics. Obviously, I see adults and would love to see all of you in the emergency department, but would also love to see your grandchildren if they came into the emergency department. So certainly we'll talk about the babies and the respiratory illnesses that they may come down with. I'm going to talk a lot about why you don't need an antibiotic, but then I'll backpedal a little bit and tell you some of the scenarios why you might need an antibiotic. So we'll talk about that. And then at the end of the presentation, I'll leave some time for you to just ask the doctor, and you can fire away on any questions that you have. So it is the most wonderful time of the year, right? It's Christmas time. We get to celebrate. We get to come in rooms with lots of people who also have coughs and runny noses and spread that around to one another, right? But it's the most wonderful time of the year. But unfortunately, it's this time of year when we all decide to get sick, right? And the question is, why in the heck do we all get sick this time of year, right? What is it about the winter that makes people get sick? Well, there's multiple theories that exist. I'll tell you, there's not a one reason why that is. But there's a couple of theories. Number one is it has to do with this nose that's right in front of your face. So this time of year, we all know we get that dried out, just kind of congested nose, right? Your nose is your body's first defense against pathogens, right? So you got little microscopic, what we call cilia in your nose that really serves as a filtration system. It's your body's air filtration system. Well, this time of year, your nose just dries up, right? That filtration system just kind of goes dormant almost, right? So that number one barrier that you have against viruses, it just doesn't work that well in the wintertime. So we're more susceptible to viruses. There's also been some studies that have looked at how viruses exist outside of the body, right? So we all know that when you're sick, you shed virus, right? You cough, you sneeze, you talk, you breathe, right? Those virus particles just kind of float around. Well, in colder temperatures, those virus particles seem to survive longer. So they simply just float around in the air longer, right? The whole business of we spend more time indoors in the wintertime, yeah, that's probably true. But there's also more viruses just floating around indoors just because they survive longer during those kind of temperatures. So probably has to do with the environment of the virus, but also has to do with our body's host defenses, okay? So that's why we're all maybe just a little bit more prone to have these infections this time of year. So let's talk a little bit about the upper respiratory infection, right? So we see this time of year, patient after patient. Even patients that aren't coming in for the upper respiratory infection have an upper respiratory infection, right? You come in and you see me because my belly hurts and I see that you have appendicitis. I bet you also have a cold on top of that appendicitis as well, right? Because this stuff is just going around. So the upper respiratory infection is sort of this constellation of upper respiratory symptoms, including the nasal congestion, the runny nose, the cough, the sore throat, right? Sometimes that extends to body aches, maybe a fever, right? All of the crud that you just don't feel good, right? You just don't feel good. These symptoms generally last about 5 to 7 days. That's what the textbook says they last, but when you actually have these symptoms, they feel like they take longer, right? And they can take weeks. I will tell you, my wife is probably my most annoying patient right now. She has had a stuffy nose for 4 weeks, and she's also had a cough for 4 weeks. And she reminds me every morning of her cough and her snotty nose. And I tell her the same thing I tell my patients. Nothing I can do, right? It's just got to run its course. It's just got to get better. So that plus the fact that she's like 35 weeks pregnant, she's just, kind of miserable, right? But anyway, so that is, so these symptoms can go on and on and on. Cough is one of my least favorite things to see in the emergency department. Not because I don't like people who have coughs, right? I don't like seeing coughs in the emergency department because there's not much that I can do for them. And unfortunately, and if you take one thing away from this presentation today, I want you to know that coughs just stink, right? That nagging cough can last for weeks, right? Bronchitis, viral bronchitis, can cause a lasting cough that can extend up to over a month, right? And unfortunately, there is not much of a treatment for cough, okay? Particularly younger kids, I want to stay away from cough medicine. Older adults want to stay away from cough medicine. A lot of those over-the-counter remedies, a lot of even prescription strength cough medicine, they can be littered with side effects, right? And they can actually make you worse, right? Especially when you start throwing in other medications that you might take. If I'm adding cough medicine on top of that, that can actually be dangerous for patients. So you take a condition that, yes, it's annoying, and yes, everyone around you is annoyed every time you cough, right? But a cough is not going to be dangerous to you necessarily, right? So it's one of those things that I counsel my patients in the emergency department and say, I'm sorry, I don't really have a good treatment, although there is one that I offer and I'll tell you about it, but it's just something that you've got to get over, right? It's just something that's got to run its course. Now, the one treatment for cough, interestingly enough, that actually has been looked at, there's people who have done studies regarding head-to-head cough medicines. The one thing that has actually been shown to be the most beneficial is honey, okay? So I do always tell my patients in the emergency department that if you have a cough, pretend you're Pooh Bear and go home and eat some honey, okay? And you could take that honey, you could take a spoonful of honey, you could put it in some warm water, you could put it in some warm tea, put it in your coffee, however you want to get it down. You can't really overdose on honey. Again, Pooh survived on honey alone, right? So you can use honey as a remedy for your cough. Now, is it going to make your cough completely go away? No, but it may provide some relief. So think about that when you have that ongoing, nagging cough, that there's got to be something you can do for me. That's kind of about it, unfortunately, okay? So for this upper respiratory infection, the runny nose, the nasal congestion, the sore throat, the nagging cough, that post-nasal drip, are antibiotics indicated in this case? No, they're not. Okay, they're not indicated. There are some specific scenarios when they are, but in general, they're not. And I remind my wife of that every morning. You still don't need an antibiotic, right? Why are we so against inappropriate antibiotics? It can't be that bad, it's just an antibiotic. Well, they are. They can be. And I'll tell you what people don't see is what I see in the emergency department, right? I see the bad news scenarios of things, right? I see when antibiotics go wrong. I see when illness goes wrong, right? We see with some frequency in the emergency department when people have reactions to antibiotics, right? You can have rashes, right? So just this itchy rash may go away, may not be dangerous. Okay, fine. It's annoying. But you can have life-threatening rashes. So there's this condition. I had this big picture to show you, but it's called toxic epidermal necrolysis. I learned something in medical school, I guess. But or we just call it TEN in the emergency department. But this is a rash that's actually life-threatening. It actually presents almost as a burn, right? If you come in with this, we got to send you to a burn center, because you're at high risk for dehydration because basically your skin starts to peel off. But you're also at risk for superimposed infections. Now that's rare. I don't want you to take away from this topic that anytime I get an antibiotic, my skin may fall off. That's not what I'm saying. But that is a potential complication to antibiotics, right? The other things we worry about are things like C. diff, right? I don't know if any of you have had C. diff, but one of the leading causes of C. diff in patients is recent antibiotic use, right? You can get really sick from C. diff as well. So antibiotics, when indicated, they're great, but they're not totally safe, right? Individually, they're not totally safe, but from a population level, they also can have bad consequences, right? Again, on my slide, I had all these doom and gloom articles that talk about superbugs are surging and so is antibiotic resistance. Stop the spread of superbugs. Antibiotics causing superbugs are a looming health threat, right? So the media loves to talk about superbugs. What are superbugs? Well, superbugs are bacteria that really no longer respond to the antibiotics that we have. So we are seeing antibiotic resistance in certain urinary tract infections, in certain pneumonias. These are bacteria that have actually essentially morphed into a form that are not easily treated, right? What happens if you have a severe infection with a bacteria that we can't treat? You may not survive, right? Whenever we use antibiotics, we increase the chance of developing resistant bacteria, right? So individually, that one prescription of amoxicillin that I give you, is that going to create a nasty superbug? Probably not. But when we do that over and over and over and over again, that's a real possibility, right? So from a population health standpoint, we also need to be careful about inappropriate antibiotics. And it's something that we think about in the emergency department and in the urgent care. So when we're talking about antibiotics for these conditions, the upper respiratory infection, I'm really a fan of less is more, right? Less is more. So who are the upper respiratory virus players? Well, there are 200 plus viruses that can cause this constellation of symptoms, right? So there are lots of different viruses that we can all kick around that will cause these symptoms, right? Viruses such as rhinovirus, parainfluenza virus, adenovirus, influenza, COVID, right? These are all different viruses that will cause these symptoms. So let's take a deep dive into influenza. So we are in the middle of the flu season in this part of the world. Influenza is a virus that spreads via person-to-person respiratory droplets as well as surface contamination. So me talking, I'm spraying virus back and forth, I can get you sick from the flu, right? You coughing, virus is on the table. I'm sitting here talking to you and I'm laying on the table and then I put my hand up on my face, right? I can get the flu from that, right? So respiratory infection back and forth and surface contamination, right? That can all cause the flu. The influenza virus generally incubates for about 4 days, right? 1 to 4 days from exposure, meaning you probably won't have symptoms until somewhere between 1 to 4 days after you actually come in contact with the virus, right? So you come in contact, that virus starts doing its thing and replicating, and then finally you show symptoms. The symptoms of influenza: fever, non-productive cough, body aches, malaise, sore throat, right? I just don't feel good. And people will tell me with the flu that I feel like I'm dying, right? I just got hit by a truck, right? So the flu can make people pretty darn sick, right? So generally the flu will cause just sort of broad systemic symptoms. Who are the high-risk groups for the flu? Well, it's pretty similar. Did somebody say me? The high-risk groups for the flu, we can kind of think of the extremes, right? The babies and the older adults, right? Those are our broad high-risk groups for influenza. And then you mix in people in between that just have significant chronic medical problems, right? Patients with kidney failure on dialysis, right? Patients with liver failure, patients with heart failure, COPD, pulmonary fibrosis, right? So when you start stacking up all of those other medical problems, it puts you at higher risk for the flu. You know, when we're talking about babies, as it stands currently, almost in general, the flu seems to be, in general, more virulent in younger babies than COVID, right? So babies in particular, we worry about with influenza. So we really want to keep our babies safe from influenza. That's why it's really, really important that when you have a newborn, I'm going to have one here soon, and we're going to go into full quarantine mode at my house, right? So we'll have that baby, but it's important to try to protect that baby, at least for the first 4 weeks of life. That's when they're most vulnerable to these infections. So if you have a loved one that has a new baby, you really want to try to stay out of that infant's face, right? You really want to try to teach others to stay out of that infant's face and really try to protect that baby for the first 4 weeks, okay? Because that is the most vulnerable time period for these infants. So should we treat the flu? Is there an option to treat the flu? Well, there is. The treatment isn't great, but it's out there. Tamiflu, I'm sure you've heard of. Tamiflu is a medication that we can give for the flu. We give it to patients who are admitted with influenza. So if you've got significant enough symptoms that you have to be admitted to the hospital, generally we'll consider giving Tamiflu. Also, patients who aren't admitted to the hospital that can go home, generally if you've had symptoms within 48 hours, you're a candidate for Tamiflu. So the studies on Tamiflu really showed that after 48 hours, there's not much benefit to it. And much like the antibiotics that I talked about, Tamiflu isn't without side effects, right? It can cause headache, upset stomach, right? Not terribly dangerous, but might be annoying, right? So if you combine that with, that it may not be all that helpful 4, 5, 6 days in, might be something that we just shy away from, right? Because if it's not going to give you much benefit and it opens you up to side effects, it's probably not worthwhile, okay? There are some treatments, but in general, it's going to be more of supportive care, and I'll talk to you a little bit about what I mean by that. So should we test for the flu, right? So if you come into the urgent care, you come into the emergency department, should we do a flu test? right? This also speaks to, should we do COVID tests, right? Should we do viral tests in little kids? I will tell you that I'm kind of the mind frame, again, that less is more when it comes to testing. I don't like to do a lot of tests to people that aren't going to change what I do for them, right? Everything we do, right? I always tell patients that in the emergency department, I'm spending your time and I'm spending your money, right? And to do things to you that really don't change what we do may not be all that beneficial. So I generally test for the flu if I'm considering Tamiflu, right? So if you come in and you're 24 hours into symptoms, then we may do Tamiflu. Yeah, I think testing for the flu is appropriate, right? If you're somebody that's coming in with lots of weird symptoms, and I'm trying to figure out where we need to go with you, is this maybe something a little bit more sinister, or is this the flu? Where do we stand? I may do a flu test at that point just to try to get information as far as what's going on, right? But in general, if it's a 30-year-old that's had symptoms for 4 or 5 days, it's probably outside the window of any kind of treatment. Probably wouldn't treat them with Tamiflu anyway. Should we test those? Generally, I say no, right? Because it's not going to change anything, right? Even if you have the flu, I'm still going to say, go home, take it easy, drink lots of fluids, right? All of those things, whether you have the flu or not. So don't be put off if you come in the emergency department or you come in the urgent care and they say there's really no reason to test, right? Just because we're not going to do anything with that information, right? So a test is not always the best. So what are some complications of influenza? Well, people can get sick from the flu. Both adults and babies can get pretty darn sick, right? You can get things like respiratory failure, right? You can get viral, what we call pneumonitis, which is inflammation of the lungs. We saw that a lot with COVID, right? But we can see that with the flu as well. Things like you can actually get heart disease, heart attacks can be precipitated by influenza. Multi-system organ failure can be precipitated by influenza. This is rare, but it's possible. And people die from the flu, right? So back in 2020, a year that we never want to have to go through again, right? We saw people at high numbers dying from COVID. But there were still people that year that were dying just from influenza as well. And there are still people that continue to die from influenza. So it is something that can be dangerous. So we have to take it seriously. But it's usually self-limited, right? Generally, you're going to get better and you're going to do fine with the flu. So this is when I had another nice picture of my grandmother standing with my grandpa. They're all like he's in a tux and she's in a nice dress and they're standing, they look great. But I have that picture up to say, when you get the flu, do what grandma used to tell you to do, right? Grandma was wise well beyond her time, right? Grandma knew that you take it easy, eat some chicken soup, right? Watch The Price is Right with some saltine crackers, take a nap on the couch, right? And take it easy, right? Those are the things that I want you to remember. That's how we're going to treat the flu, right? Do what grandma would have told you to do, okay? Super important. All right, so now let's talk about COVID, right? SARS-CoV-2 is the virus that causes the constellation of symptoms called COVID-19. I think you all have been so COVIDed out, I could probably pass the microphone off to somebody, sit down and let you talk about COVID, right? We all know about COVID at this point. COVID causes the upper respiratory infection that we talked about before, right? Runny nose, congestion, cough, body aches, fever, sore throat. COVID does, though, cause a little bit more of the GI stuff, right? So you can get the diarrhea, you can get the nausea and the vomiting. I also will frequently see COVID present as, I just don't feel good, right? Especially in elderly people, I just don't feel good. I don't have an appetite, I'm just weak, just kind of bleh, right? One of the first things I do when I get a bleh presentation is I check for COVID, right? Especially this time of year. And sometimes it hits, right? And it's COVID, and that's the answer. That's why you feel bad, because you have COVID. So COVID can do that as well. COVID, again, affects the same groups as we talked about before with the flu, maybe less so with the younger kids. Generally, the younger kids just get a snotty nose and a cough. There are cases of more severe COVID in kids, right? There's these inflammatory processes that can happen in kids, and certainly some kids can get very sick from COVID. So the point is not to say kids don't get COVID, right? But in general, kids do pretty well with COVID, right? It's the older adults that actually get hit by COVID harder. Older adults, again, patients with chronic medical problems, kidney disease, heart disease, lung disease, right? Those are all age groups or folks that get affected. The other thing that's interesting is, we've had 4 years to study COVID, and there's like just a plethora of information out about COVID. One of the things that's interesting is physical inactivity has been linked to risk of severe COVID, right? So obesity also is that way as well, right? So obesity is a risk factor for severe COVID. So if you are inactive and you are obese, that's an increased risk of COVID. So what I would recommend is at least always working on some level of physical activity, right? You don't have to go lift 100 pounds at the gym. You don't have to go kickboxing, right? Just walk a little bit up and down the block, right? Just try to stay active as much as it's possible for you. And that's one of the most protective things that you can do for COVID. Complications of COVID, respiratory failure, we all heard a lot about that, right? Remember in 2020, we would hear about all these people on the ventilator, right? And having these terrible lung diseases. That was real. That was scary. It was terrible. Right, I remember working in downtown Indianapolis when COVID kind of started flaring up, and it looked like a war zone in those emergency departments, right? A war zone. And these patients would come in gasping for air, and we would have to treat that. And then you'd go home, and I was so worried about taking COVID back home to my wife that I would take all my clothes off in the garage, and I would go straight to the shower, right? And then I would, be at home, thinking about everything that happened. Then you go back and you do it the next day and the next day and the next day. Certainly that was a time that we don't want to live again, but the folks that dealt with that on a daily basis, the nurses who were at the bedside for these people, absolute heroes during that time, absolute heroes. And we were all worried at the time about getting sick ourselves, right? But we got to take care of patients and we got to do the right thing, right? So what a time that was, certainly. But so the respiratory infections is certainly a kind of the big, bad, scary player for COVID, or the big, bad, scary side effect. The other things that we worry about, and this probably related to the respiratory symptoms that patients would have, is COVID also increases your risk of clotting, right? So you can develop things like blood clots in your legs, blood clots in your lungs. There is some maybe higher incidence of things like strokes as well among COVID. So those are side effects that can be downstream. I had a CT scan that showed the lungs of patients with severe COVID. When you look at lungs on a CT scan, they're supposed to be black, right? Black is air. But these lungs were just like white everywhere, just white splatches everywhere through the lungs. That's all inflammation, and that's what we call ARDS. Which is just a significant respiratory infection that happened with people in COVID. Now, the fortunate thing is we're not seeing as much of that as we used to, right? I will say anecdotally from my work in the emergency department, I have not seen a really, really sick respiratory patient from COVID in a while, okay? So I think that variant of COVID is kind of behind us, hopefully. Now, there's always a chance that with a new variant, we could see people get sicker again. Again, not that people aren't getting sick from COVID, but I'm not seeing that terrible lung pathology that I did a couple of years ago, which is a really good thing. So what are the treatment options for COVID? What is that commercial? It's like if you have COVID, think Paxlovid or something. The guy from the Chiefs, Kelsey, is on that commercial. So that's a medication that's out there, and that's helpful. Paxlovid is an antiviral that has been demonstrated to maybe reduce the duration of COVID symptoms and to prevent you from going on to get severe COVID. So it's a good option. My mother-in-law had COVID, got Paxlovid. She did really well with Paxlovid. The problem with Paxlovid, though, is it's a little bit of a dirty medication, meaning that it interacts with other medications. So generally, patients that I would want to prescribe Paxlovid to are patients that are high risk, and because they're high risk, they're generally on a lot of medications, right? So I have to spend a little bit of time if I'm thinking about Paxlovid, thinking about their medication list and if Paxlovid is going to interact with a lot of their meds. There are some patients that we may prescribe Paxlovid to that we have to just adjust their medication list and say, hey, for the next 5 days, I don't want you to take this medication that you normally do. But sometimes that's not an option, right? Sometimes the medication that we would need to take them off of is just too important for them. So sometimes Paxlovid is not an option for patients just because of the other medications that they're on. So you may come in contact with Paxlovid. Remdesivir is another medication that we can give for COVID. That is an IV infusion that used to be kind of an inpatient medication. There are some studies that suggest that outpatient use of remdesivir is potentially beneficial. That is an IV infusion, so that has to be done through the infusion center. So if you were to get remdesivir, it's like a 3-day course that you'd have to come in for an IV infusion. Again, may reduce the duration of symptoms and may prevent you from going on to get severe COVID. And then the other medication that you may hear that's out there that isn't used quite as much is this medication called molnupiravir. That's another antiviral medication, but that one has a lot more side effects. So it's a medication that we generally reach to as sort of last line for patients, but it's out there and it's an option for the treatment of COVID. Again, I've got the nice picture of my grandmother standing up on the screen telling you, do what grandma said when you have COVID, right? Watch The Price is Right. You'll get better. Okay, so again, COVID is going to be likely self-limited. Over 5 to 7 days, you're going to start to feel better. If you develop respiratory symptoms, chest pain, significant shortness of breath, unable to keep down fluids, come see me, okay? Because sometimes we do have to admit patients with COVID, right? But in general, it should be a pretty self-limited disease. All right, so what about the babies? Picture of Owen when he was like 10 months. He's super cute. If you want to come up and look at the screen, you can see him. So what about the babies? Well, the babies get sick this time of year too. So we not only get slammed with sick adults, but we get slammed with sick babies. As you can tell, there's lots of sickness in the emergency department this time of year. Now the babies get a different constellation of symptoms. This time of year is what we call bronchiolitis syndrome, or season, I'm sorry. They get this thing called the bronchiolitis syndrome. Bronchiolitis is an inflammation of the airways, okay? So you will see these babies coming in, coughing, pouring snot, breathing really fast, right? You'll see their little bellies just kind of doing this dance, right? They do what's called retracting, where you'll see their lungs or their ribs flare, right? Their nostrils flaring. They're really working hard to breathe, right? So bronchiolitis is this time of year, and that's something that we have to be worried about with our babies. Bronchiolitis can make kids really sick. Bronchiolitis is caused by a viral infection that causes airway inflammation. So they essentially just get this slurry of snot and mucus and dead lung cells in their airways, which makes it harder to breathe. Babies in general breathe out of their noses. They're sort of what we call obligate nasal breathers. So when they have nasal congestion, you can imagine that makes it really hard for a little baby to breathe when they primarily breathe out of their nose. So this can be dangerous for them. So bronchiolitis is the syndrome that we're talking about. There's multiple causes to bronchiolitis. COVID can cause bronchiolitis, influenza can cause bronchiolitis, para-influenza virus can cause bronchiolitis. But the one kind of player that everybody seems to know about, again, that's featured a lot in the media is RSV, right? Is that virus that can cause bronchiolitis. I'll tell you, there's a little bit of RSV phobia because of what we hear in the media, that RSV is just this terrible, terrible virus. It can be. Okay, there are babies that can get really, really sick from RSV. But if a 2-year-old gets RSV, generally they're going to be okay, right? We all kick around RSV likely, right? We've all probably had it, and it's it's one of the viruses that cause some of our upper respiratory symptoms. But RSV can certainly be dangerous in young babies. It can be dangerous in kids in general, but the vast majority of kids are going to present in RSV with runny nose, nasal congestion, cough, the upper respiratory symptoms, okay? But why does RSV get dangerous? Well, like I said, it's because it causes this respiratory depression, right, or this respiratory distress from that sloughing of those skin cells, or sloughing of the lung cells. RSV generally presents as this sort of curve. Over 3 to 5 days, babies get worse, and then they start to get better. So if I have a child that comes into the emergency department at day 2 of illness, and they look like they're really working hard to breathe, that's a baby that I'm worried about, right? Because they're only to day 2. And the textbook says that they should get better over 3 to 5 days, right? So they're probably going to get worse, right? So generally it's a 3 to 5 day progression. It's most prevalent, again, during the winter months. Premature babies, very young neonates, and really that age group less than 3-ish months, less than 6 months, those are the high-risk babies with RSV. Not that every baby that comes into the emergency department with RSV at 4 months needs to be admitted to the hospital. If they look good, they can go home. But that's that higher risk group that we think may potentially get worse. So what's the treatment for RSV? Well, the treatment is just supportive care, right? Suctioning out their little noses, suctioning out their mouths, right? If they need supplemental oxygen, we give it to them. If they need more higher supplemental oxygen, we hook them up to this thing called high flow nasal cannula, which kind of pushes air at a higher pressure into their lungs. Unfortunately, occasionally, these babies go into true respiratory distress where they have to be intubated and they have to be put on the ventilator. Again, that's not every baby that comes in with RSV, but we have a handful of those every year that we have to intubate. Generally, they do okay, but we do have to take their airway in those cases just because they get so sick. Okay? So is there a role for antibiotics after I have talked about all of these viral syndromes and I've told you about antibiotics? When should we do antibiotics? Okay? Well, let's think about 2 main reasons to do antibiotics in these cases. Number 1 is going to be for bacterial sinusitis. Okay? Your upper respiratory infection can transition into a superimposed bacterial sinusitis. Really, the cutoff on that is if you are having these upper respiratory symptoms and true signs of sinus involvement, meaning I've got this sinus pressure here, I've got this sinus pressure here, my nose is still just pouring out this green-yellow goop, right? And I'm getting worse, not better. And I may now have a fever and not get better. That's probably an indication for an antibiotic, right? That's what we would treat a quote-unquote sinus infection for. But let me tell you, in general, sinus infections don't need antibiotics. They don't need them. Those that are getting worse over 10 days with the fever, with the worsening pressure, pain, nasal congestion, that kind of thing, those are susceptible to antibiotics. But the vast majority of sinus infections do not need antibiotics. The other thing that we would use antibiotics for in these cases would be a true pneumonia, right? A true bacterial pneumonia. I've got some pictures of x-rays that show what pneumonia looks like on an x-ray. That's treated with an antibiotic. Unfortunately, when you have a viral infection, the virus breaks down the defenses in your lungs. So you may start off with the flu, and the flu does what the flu does, and the flu may sort of disrupt your lungs, and then your lungs get a superimposed bacterial infection. We see that commonly. That bacterial infection does respond to antibiotics, right? We would treat those with some form. Not everybody with pneumonia needs to be admitted, but there are oral options and there are IV options. And we would have to, case-by-case basis, decide if you would be a patient that could go home or would need to stay in the hospital, okay? Pneumonia typically presents as cough, shortness of breath, fever, right? Those are the 3 main things that I'm thinking about in the emergency department when I'm evaluating somebody for pneumonia, okay? So those are the 2 big things that we would treat with antibiotics. All right. So with that, the kind of key takeaways that I want you to remember. Upper respiratory infection, generally self-limited. Do what grandma told you to do. The flu can be bad. We know how to treat it, or there's a few options out there. May or may not need a test. Most of the time gets better. COVID infection can get worse, but there are treatment options. You have to talk to your doctor if those treatment options are right for you based upon the medications that you take. Those treatments are generally best within 5 days. So much like the flu is 2 days, COVID is 5 days. If you're outside that 5-day window, those treatments are not all that beneficial. Okay, so 2 days for the flu, 5 days for COVID, treatments available. For the babies, stay out of their face, right? Young babies, stay out of their face. Protect the babies, right? They can get sick. And then finally, antibiotics for the sinus infection that's progressive and you're getting worse. Most sinus infections don't need antibiotics. Antibiotics for pneumonia with cough, fever, shortness of breath. Hopefully we can get you home if you have pneumonia, but sometimes we have to admit you to the hospital. What questions do you have? This is your chance to ask the doctor.
Why do you guys prescribe an antibiotic if it's not going to do any good?
Who, in general, what scenarios?
Okay, let's say you go to ear, nose, and throat doctor, and they put you on an antibiotic.
So it depends, and I cannot speak to other docs, right? There's always this balance, right, of what does the patient expect of me? Unfortunately, and that's real life. Patients sometimes, and that I'm not saying that's at all the right thing, right? And that's what we need to that's why we need to educate that antibiotics are not always the right thing, right? But there are other reasons, right? Especially ear, nose, and throat docs when they're seeing you, right? They're seeing a select population, right, that may truly have bacterial sinus infection, right? May truly have an ear infection, right, that they're prescribing antibiotics for. So that in of itself, I can't speak to, why they did, why they didn't, why somebody did, why somebody didn't. It's really a conversation that needs to be had with your doctor, what is best for you. And every patient is different, right? Every patient is different. When it comes to the general upper respiratory infection, right, what we talked about, that first you've had it, this is the very first time that you've had it, right? I'm presenting with that runny nose, with that nasal congestion, with whatever. In general, those don't need treated, in general, right? But there's always caveats to that, right? There's always caveats, okay?
What do you do if you have a sinus infection?
Do what Grandma told you to do. Treatment for, they do. So treatment for the sinus infection, right? The sinus infection, you can treat, Tylenol is great. So Tylenol is great for the pressure, right? If you're able to take things such as NSAIDs or ibuprofen, right? Ibuprofen is great for that as well. I like to use things like nasal saline. So nasal saline sprays just sort of help to open up and kind of flush out your nose. So that's helpful, right? That neti pot is fine. I've always been a little bit, for me personally, the thought of spraying that up and it coming out my nose and whatever, that's not ever been something that's appealed to me. My dad swears by the neti pot, but certainly that can be helpful. Flonase is helpful for things like allergic rhinitis or allergies. In general, for a viral cause, Flonase is not super helpful. Flonase is helpful again for more inflammatory things. So when it's allergy season and there's pollen flying everywhere and whatever, Flonase really works for that. For the viral syndrome, that's not always the case, right? That doesn't always work.
We ain't doing nothing right.
So, unfortunately, for the quote-unquote sinus infection, there's just not a ton of great treatment options, right? It is just one of those things that's just annoying. And I get it, right? I get it.
course like the flu.
It's got to run its course. And again, much in the same way, I tell my patients, and I hate it, right? I got into being a doctor because I want to help people, right? That's what we do, right? I want you to come in the emergency department, you feel terrible, and I get you better, and you go home and you say, man, that guy was great, it made me feel better, and whatever. That's what I want. But unfortunately, that's not always possible, right? We get sick, right? We just get sick. And there's not always a treatment for everything that we get sick from, right?
So when I had sinus infection, I just had to suffer with it.
Watch Price is Right.
Watch The Price is Right. Yes. Okay. Yes, ma'am.
I didn't hear you say anything about Alka-Seltzer Plus, the cold one, not the one for indigestion. So where does that fit?
I think that would be fine. Yeah, I mean, I think that's one of those treatments. I'm not sure, how well studied that is. I don't think there's a whole lot of harm to it, so I'm okay with that. I have issues with treatments that maybe don't have a lot of benefit, but carry a pretty good side effect load as well, right? I don't want to give you meds that have side effects if it's not going to help you, right?
And Alka-Seltzer Plus does. I mean, it tells you on there, not to take it over 7 days.
Sure.
Can damage liver and this and that over years. But since you didn't mention that, I didn't know
Sure,
that.
but I think a couple of those kind of things, like and it helps, fine.
Pressure, you know, with a sinus infection, you got that pressure.
Yeah.
So what's that? Just have to run its course?
It can. Now, again, remember, when you get to that 7-10 day mark and it's not getting better, there is an indication sometimes for antibiotics on those, right? So that is always the kind of that's the out there that if you're not getting better 10 to 14, 7 to 10, 10 to 14 days, antibiotics can be helpful, right? Because you can have superimposed bacterial infection of the sinuses, and those respond to antibiotics, right? So that would be a case, right, where somebody may say, hey, this is a good option for an antibiotic, right? But again, based upon you individually, right? That's why these recommendations are not always a one-size-fits-all, right? You individually, your doctor knows you the best, right? So there are indications for antibiotics, but the textbook would say 10 to 14 days. Yes? Yes, anything else? All right, thank you so much for your time.
Thank you.